For some patients, surgery is a very intimidating and sometimes scary ordeal. Just the thought of being put to sleep and placing total control into the hands of doctors and nurses, only so that they can cut into you. It's frightening. A whole list of questions run through your head. Will I wake up? Are they going to operate in the right area? I hope they don't leave anything inside me. Thousands and thousands of surgeries are performed each day. Almost every one of them go off without a problem. With Miss Cantu, this wasn't the case.
We're taking you beyond the red line. I am Dr. Carrasco. I specialize in treating those who suffer from pain. This is the Dr. Carrasco Show.
Ms. Maria Cantu is a 73-year-old Hispanic female who lives in Laredo, Texas.
La familia, pues, es lo máximo que tenemos. Dos hijas, dos nietas y una bisnieta.
I saw her first in January of '09. And this is a lady who was perfectly normal, okay? 8 months later, she was perfectly normal, living her life with her and her husband, just happy as could be.
Yo no soy persona que quiera estar sentada, así es que, y sobre todo, extrañaba mucho mi cocina, porque tengo muy chiflada a toda mi familia. Yo estoy acostumbrada a estar mucho en la cocina, a cocinar mucho, mi repostería, mis pasteles. Abandoné mucho mis plantas, que es lo que más amo. Y eso me hacía sufrir. Es que te imaginas, ¿eh? No, sí, esto fue una cosa que no puedo describir. Y eso sí lloré mucho porque ya no funcionaba igual. Al grado que no podía ni siquiera con media taza de alimento. El no poder atender a mi familia como estaba acostumbrada. Me sentía muy limitada. ¡Ay! En 2 o 3 ocasiones, al tomar la ensalada, tuve que dejar caer el tenedor por el dolor.
It's so important that we recognize that this is a case that she had to suffer to get better. You know, her story, when her and her husband came to see me, apparently in April of '08, she went in for a simple hernia surgery.
Bueno, pues francamente no sé si, porque soy un poquito desesperada con mis plantas, a andar agarrando algo pesado, en fin, no puedo asegurar qué fue lo que pasó, pero sí sentí una noche mucho dolor y resultó que era una hernia.
If you kind of think of the abdominal wall kind of like a shell, the wall of the abdomen is made up of muscle and connective tissue. A abdominal hernia is a defect in the abdominal wall where things from within the abdomen can protrude outward.
Entonces se quedó para el día 13, estuvimos aquí, de abril, y el 14 fue la operación.
Basically, when we fix hernias, what you have to do is close the hole. We'll usually make an incision. We find the defect, and usually it's pretty easy. What we oftentimes will do is try to create a space behind the abdominal wall where we can place mesh to cover the defect. People sometimes ask, well, if I don't do anything with this, will that hole just scar down and close on its own? And the answer is no. I mean, hernias won't go away. Just with time, they tend to become a little more complex and a little more troublesome, both for the patient and for us.
Entonces estábamos en el hotel y a las 6 de la mañana teníamos que estar en el hospital y todo estaba bien. Recuerdo, no sé si bajamos un piso porque no lo voy a mentir, pero sé que me llevaron a una sala donde me pusieron una bata y me dijeron que me iban a preparar. Pero no podía encontrar la vena y era mucho lo que estaba fastidiando. Viene el doctor a hablar conmigo y dice, en unos momentos más te pasamos a cirugía.
She's usually given a sedative now in pre-op area. Subsequently, she goes to surgery.
Pues nomás vi que estaban mis hijas y mi esposo, pero ya después no recuerdo. Ya me metieron a cirugía y ya no supe.
The surgery for hernia repair has become very common. It's one of the most common operations that we do. Mortality rates have to be less than 1% for most outpatient hernia repairs. Usually it's an operation that lasts anywhere from an hour to as long as 3 hours, depending on the complexity of the hernia.
No, de estar preocupada por la cirugía no estaba. He tenido otras operaciones.
Obviously, hernia surgery is much less complex than doing brain surgery. I wouldn't do it in my garage, but it's something that I think most general surgeons have a pretty good grasp on. It's really a very low risk. The immediate risks are bleeding, and then in the first few days, you worry about risk of wound infection.
Now, it's very difficult to cover all the possible things that could happen to a patient when they go to surgery, when there's so many things that could happen that are out of the normal doctor's control.
One of the best means of caring for patients is to try to inform them all along the way of what's going to happen next, you know, to try to put them at ease, because it's an environment and a situation that produces a lot of anxiety.
Were you worried? No, not at all. We just trust that we're in good hands and we have a lot of faith in God.
Use aseptic techniques when we're doing the surgery, trying to maintain a sterile field. We usually give them preoperative antibiotics, particularly if we're going to try to minimize the risk of wound infection. Nurses check patients, do a historical review, look at the patient's medications. They're monitored not only intraoperatively, but in the postoperative period.
There's so many checks and balances. We've been in the OR, we say, what are the counts? Are the counts correct? They count all the sponges. They count all the instruments. They count all the staples. They count all the sutures. They count everything. It says there's nothing left in the body.
You have the surgery, and then we're not going to rush you out of here. You know, we're going to make sure that it's safe for you to go home. I tell you, it's a very safe process.
Al salir de cirugía tampoco lo recuerdo porque estaba con la anestesia.
Well, after surgery, obviously you're taken to the recovery room and you kept there, depending on the type of procedure and the doctor's orders, maybe there for an hour, maybe there for 2 hours, maybe sometimes even longer. After that's done, then you're taken to your room. If you're outpatient, then you're obviously discharged, the IV's taken out, you're given all your instructions and you go home with your family. If you stay overnight from the recovery area, they generally take you to your room and you'll get IV fluids through the night, especially if you had surgery, since you won't be able to eat very much. Sometimes we need to give you fluids intravenously, so you go back up to the floor.
When she came out of surgery, we actually don't even know who made the mistake.
No sé la hora, porque no voy a mentir. Pero cuando estaba volviendo en sí, mi brazo me dolía. Y yo le decía a mi esposo, mi brazo me duele.
She had a hernia repair. We're looking for problems in here. We're not looking for problems over here.
Pero no podía encontrar la vena. Y era mucho lo que estaba fastidiando. Fue a traer a una persona, como ella dijo, especialista.
So a typical situation for an IV, for example, let's suppose she'd lost the IV or the IV became non-functional. The nurse could try, as I understand it, she can try twice. If she's not able to get an IV because of the patient's condition or because of her unable to do it, talent or experience or something, then they can call an IV team. And the IV team comes in and says, okay, let me bring somebody with a lot of experience that all they do is put in IVs. They go and put the IV. Patients intravenously or through your IV is going to help you go to sleep if you need to for resuscitation or for other reason. But generally, you haven't eaten for many times 6, 8, or 9 hours or more. So you need some fluids. And also the anesthesiologist is going to put you to sleep through that IV. He's going to give you medications intravenously or through your IV that's going to help you go to sleep. But once you decide, let's suppose in her that we decide to put it in the antecubital area or right here in very commonly placed right here at the elbow. Then what you do is you identify the area, you will put a tourniquet over the area above it to keep the blood pooled in this area. Once you put the tourniquet there, then the blood vessels will tend to pop up. You're going to clean it off sterilely. What happens then is you advance this now into the vein. You connect it to the tubing and you open up the fluid and you'll see how good the fluid runs. Once that's done, then we consider it to be a good IV.
Que no batalló nada, solamente limpió aquí mi brazo y en esta vena me puso el IV. Pero ya había dejado ahí el torniquete.
When you put the tourniquet on, they're done pretty tight to get the fluid to pool. If you don't take off the tourniquet, what's going to happen? The blood's just going to go all over everywhere. In this case, when you leave the tourniquet on, if you're very quick or you elevate the arm, so the gravity is helping you, then you won't have a lot of blood spurring out. You hook up the tubing and you keep going. You think it's a great IV. This, coupled with the change in personnel and the length of the gown, which covered the tourniquet, was probably the inception of the problem.
I mean, that's a, you know, you start the IV, they don't take the tourniquet off, and then she goes to surgery, and she's asleep during the time that the tourniquet's on. I don't know that I've ever heard of that happening.
I've never had to tell a patient, you may get problems with the tourniquet left on. Never. I mean, that's just not something we think about.
Y él fue varias veces con la enfermera y decía que era por el IV, pero nunca revisaban mi brazo.
Part of the assessment is how's the patient doing, how's the wounds, how's the incision, is she awake, is she alert, is she sleepy, does she have pain? They thought it was pain into the incision, so they said, well, it's common to have pain. And generally, because they've had a hernia surgery, you're not going to feed them a pain pill, you're going to give them IV medications. So you go and you flush some pain medication through the IV, open up the IV, it's running good, everything is fine.
Se dieron cuenta hasta las 2 de la mañana que viene esta señorita filipina también y se quedó asustada. Dijo, oh no, cuando me va a quitar la bata para cambiarme, van viendo mi brazo, que era de esta parte de aquí, acá, oscuro, negro, y ya había vejiga. Si puedes figurar, fueron como de las 7 de la mañana hasta las 2 de la madrugada. Casi 18 horas.
You take the patient back and they undergo an anesthetic, they can't tell you that there's pain here.
Part of the assessment is how's the patient doing, how's the wounds, how's the incision, is she awake, is she alert, is she sleepy, does she have pain? She was able to move the shoulder. She had a frozen shoulder now because of not using the arm. She had a mixture of neuropathic and somatic pain. No. Alcilometer. And so we felt that we needed to treat it multiple ways. For this kind of case, I mean, it's 18 hours is a lot of time to have a tourniquet on. You can't gauge, you can't measure how much trauma was done. The only choice I have is to do the best I can for this patient. She'd already been seeing doctors for 8 months. She wasn't getting better. We had to get her better. We don't have a choice.